Hi there, I'm Tyler Simmet, and I'll be working with Evelyn Schwalenberg, our master educator, who's been a faculty program developer for over 12 years now, and is going to be talking to us about teaching styles. Evelyn?
Thank you so much for bringing me here today. So I think it's really important to talk about this topic, particularly as our profession's expanding. We have a lot of clinicians that are being asked to be a part of the educational environment and scenarios. I think it's really important to talk about the different types of teaching styles and to make them successful as clinical educators.
But doesn't everyone have their own intrinsic teaching style that they just do because it's who they are?
They do, but the interesting thing is you can actually learn different ways to be more effective in teaching and have a larger range to reach out there to the different level of students that come to you. So our goals for today is to really have some opportunity to talk about some specific principles of adult learning. I think if we're going to be teaching, most of our learners are adults, so it's important to understand their perspective and some of the aspects regarding adult learning.
Are all of our students adults?
Chronologically, yes.
How about thinking-wise? Is that a process, or can you be a partial adult learner?
You can be adult learners, but how effective they are, where they are in that process, really depends on the types of skills in clinical thinking that they have already developed to the point where you have them in your office. We're also going to talk about the four different verbal teaching styles, because in the clinical settings, most of our teaching is in fact at the bedside, it's verbal in nature. So we're going to talk about those different styles. We're going to look at the advantages and disadvantages of those styles and what are the ways why you would like to choose particular ones. And as you've already mentioned, we actually have a preferred style. Most of us have a particular style that we use all the time. But the important thing is to have a range of styles so we can meet the needs not only of our patients in making sure they get the care that they need, but we make that educational environment very enriching for the learner. So that's our goals for today. So to start off, we really should talk, why do we teach? You know, when we're in clinical practice, it's really about being productive and taking care of patients. That's our primary goal. But you know, why do we teach? It often isn't the monetary rewards that we're going to be getting.
Sometimes people can't help it. It's part of who they are and that they're going to teach.
That's right. And in different faculty development sessions that I've done over the years, I've kind of have some really understanding of some common responses. And so let's take a look at some of those common responses. And as you've said, most of the time it's really a sense of duty. They realize that they learned in an apprentice model. They have a sense to feeling that they needed to pay back what others have done for them. So they want to do that. Others are very invigorated by having a student in their office because they're challenged. They really feel as though learners keep them on their toes, and they like that opportunity to have learners be there and challenging them. But they also acknowledge that learners often bring them new skills that they haven't had, particularly around technology. These students that are coming to us, or learners are coming to us, are very digitally oriented. They know how to search different databases, and often that's a thing that they give back to their preceptors, and preceptors really like that. Students like that because it really makes it a reciprocal relationship. So in addition, we have to really talk about adult learners. Why are they different than maybe your children that are learning in the school system? And so some of the ideas that we have to think about is that really adult learners need to have a reason to be engaged. They want to be engaged and active learners. They have to know that what they're learning is really applicable to them almost immediately or in the very near future. So they have to meet their needs and their goals, has to be active, has to build upon previous experiences, because that really helps them, especially in a clinical scenario, developing that critical thinking. How do you put all that pieces together, making medical decisions? That's really very important.
So when you move from pedagogy and teaching kids to andragogy and teaching adults, are the skills the same?
They're very similar, but again, in working with children, you're really building that base, and working with adults, you're really having to draw upon that base and having new connections and trying to move forward with previous knowledge and developing those clinical reasonings that were very important in patient care. So when we think about what we're talking about, it's really teaching in the clinical setting. And so when you look at the literature, you look at student surveys, there's some pretty common things that really make clinical preceptors effective. And so we should probably think about some of those ideas too as we talk about clinical styles. And some of the common things that come back is that preceptors are enthusiastic about teaching. You know, and I think you can remember back when you were a student, what are the people who really stood out? I mean, you learn from good teachers and you learn from bad teachers. You learn from ways you wanted to continue to engage learners, and you learned ways that you said, you learned, but you say, I'll never do that. I'm not going to do that. So those who are really very enthusiastic about teaching and engaging the students in the learning environment are the ones that really rate pretty high. And the other important factor of effective clinical teachers is giving feedback both positive and negative at a very timely fashion. Learning that you didn't do something right 6 weeks after the rotation ended, not the right time to get the feedback.
So in teaching adults, is it always formal or can it be informal? Do you need an assessment of the learners for it to be teaching?
Well, your assessment certainly, so you have a very good question. So as far as you do your assessment, the formal formative kind of evaluations really are done as you go through your teaching environment. It allows you to assess where they are against a benchmark, give them pointers to make changes, and so they can make improvements. Because if they don't know where the benchmark is and where they are in relation to it, it's hard for them to move along that continuum. A more summative evaluation or assessment is really at the end of the rotation, at the end of the learning unit, and you're making a judgment about did they make the mark or not. So it's always assessment, but how you're applying it and where you're applying it makes the difference.
Because sometimes preceptors feel if the student is following me around, they'll see what needs to be done, and if they're smart enough, they'll learn.
Well, I think that could be a reasonable assessment, but that leaves a lot of unsaid or potentials for stumbling in a teaching environment. If you really want to be an effective clinical educator, you need to be communicating to the students, assessing where they are, making it very clear where they're going and where the gap is in between to help them make that mark.
So is the assessment meant to put a pressure on them and increase the stress level so that they're encouraged to learn?
Well, I think for some learners they might feel stressed, but the whole idea is you're laying out that pathway. You're allowing them to understand where the benchmark is and allowing them different ways and techniques to get to the desired endpoint. Some might feel stressed, others might really interpret that as excellent guidance. So as you look at the different teaching styles as a clinical teacher, the really goal would be to enhance your teaching skills. So you have a larger repertoire to work with the learners, because you are going to get different level learners. So where they are on that continuum, you might want to alter your teaching style. It makes you more engaged, it makes you more enthusiastic about teaching. But at the same time, clinical teachers know we're balancing not only that teaching encounter, but the actual direct care and outcome of patients. So patient care certainly comes primary, and the outcome of that patient care is very important. We're trying to interject teaching at the same time. So sometimes our style is determined by looking at what the clinical scenario is, how critical or how urgently do we get to the point of care for the patient, but also where are the learner's needs. So it's a very balancing point to have, and having the different teaching styles helps you do that. And teaching styles come on a spectrum. So understanding that spectrum will allow a clinical educator to really understand better, be better observers to that interaction, what's going on, and therefore being able to select from that different styles what's most appropriate in making that particular educational venue much more effective. So we're going to spend some time talking about the different styles.
Are there preferred teaching styles for different venues? So if you're precepting, do you always want to be an assertive teacher so you move things along, or is it variable and open?
It's variable and open, and as I just mentioned, it really depends upon what the educational objective is for that particular scenario and what is the other competing patient care goals that are needing to be done. So we'll go over some of those different styles. So when you look at the spectrum, it really runs the gamut from a more teacher-centered side of styles to a more learner-centered styles. And what that means is that the teacher-centered side really makes the workload and the directiveness more on the teacher's responsibility. And we'll run through some examples of that. And those that fall on that continuum more assertive and the suggestive styles. And as you come to the middle, as you might imagine, it's a mix between the two. And on the other side, more learner-centered, meaning you've put most of the work or most of the structure around that learning environment or that learning session is really heavily weighted on the student. So we're going to talk about those different styles. But in where, for example, an assertive style, if you are in the emergency department, as I know you're an emergency physician, and you have a patient who's not doing well, you're going to give that learner, you want to make this a learning environment, not close them out, but you might be very assertive and directive in your questions because it's really about taking care of the patient. If you're more in a relaxed environment and your patient's doing well and your student's struggling, you might give them a little more room to kind of walk them through their thought process and get them to a conclusion point. So how you choose your style and what's appropriate is a combination of where your learner is, your learner objective, and the patient care that's being delivered at that time.
Are all students capable of learning in all styles? Can you use a facilitative, learner-centered style with everybody?
That's a great question. Just like teachers prefer a particular style. I think students, and if you can remember back when you were learning, you probably had a particular style that felt better. You might have felt better reading and being demonstrated. You might have been better at watching videos. Everyone has a different style, and of course, depending on what's happening in the environment, they might be more receptive to being more directive, or they may feel insulted that you're being directive. So it's a balance. And so part of that, debriefing about a clinical scenario is important, but being aware that there's different styles and how you can switch between the two, and knowing why you wanted to use one versus the other will help mitigate some of those challenges or conflicts that may occur because of the conflicts in styles. So it's a very good point. So let's talk about some of the very specific styles. So on the teacher end of things, there is, again, the assertive and the suggestive. So on the assertive side, it really emphasizes the teacher being mostly in control. You're setting up the framework. And again, it could be that you're being very short and concise because the patient's very critical. It could be that your learner set of knowledge base is fairly small, and you're really trying to be very directed. You're very directed in your questions. It's not necessarily open-ended. When you get to the suggestive side, again, you're building on what the student may have had as a base of education, and you're framing around drawing out some of their knowledge and helping them make those connections in their clinical decision making. So you may say, we're talking about hypertension today, we're talking about treatment. Tell me, compare and contrast these two treatments. So you're going to start to create those clinical connections and how they're actually going through their clinical decision making.
So is the student engagement in this kind of learning, is that because they're in a classroom or in a learning scenario? Or is there something internally motivating that makes it more andragogy for adult learning?
Well, most of what we're talking about today is actually in the clinical, this is a clinical-based kind of education. So this is at the patient bedside. You can certainly have debriefing at the end of a day, but it really often is, you're talking around a patient scenario which they have been actively participating in.
Because one of the things I like doing is making sure the student is engaged and commits their own ego into it by saying, here's what I think, or here's where I'm coming from. In an assertive directive style, they don't have that engagement yet, unless it's a very clearly hierarchical, I'm teaching you this, and here's what's going on.
That's excellent, because as you just identified what your preferred style is by describing what you do. What you do is very collaborative. So you are more learner-centered in the way you approach things. And so that's probably your predominant style. My guess is, all of us as being patient care providers, I'm sure all at times, whether we prefer it or not, can be very assertive. I'm sure in the ER, there are plenty of times that you are very assertive in the way you approach the teaching.
Well, if it's factual knowledge and they don't have the basic knowledge needed to move ahead and think, I like the assertive style to create the pressure that they learn. Do you know this fact that you need to decide to send this person to the emergency room or keep them here in the office?
That is true. So as you move down the different spectrum, it may be about where the learner is. Now, sometimes learners have performance and anxiety performance issues, so they may actually know that information, and that style paralyzes them in trying to get that information out. And so sometimes recognizing, because you've spent some time with the student, you've seen them demonstrate it in other ways, because they've written out maybe a written SOAP note, you know they have it, so you're going to have to approach how to get that information out of them and for them to build the confidence. And so you may have to switch styles. You may know they have it in there, and you just have to demonstrate it in a slightly different way. Or it could be it's your first year student out in your clinic for the very first time ever in patient encounters, and you want to give them a goal that they can meet. And so you know that they've at least talked about what are the categories of hypertension medications, and you want to hit an easy goal to make them feel better and start to build confidence. So there's different ways that you can move across the spectrum to make it effective. Great questions. So to go on to the more learner-centered side, as you just talked about a little bit, so the learner-centered side is really more centered on making the learner part of the driver or setup to the encounter. So the collaborative side, as you just mentioned, is just that. You would say to the student, where are you in your thought process? It's very open-ended questions. They're directing the interaction. So depending on how they answer, so if you want to give that student an open end and they say, geez, I'm not really sure, you might then switch back to a more suggestive style. We've talked about hypertension before. I know we've talked about this. Let's go back to those, and you might start laying out that framework or pathway a little bit more for them, and then see if they take it the next step. And if they don't, you're back to more assertive, maybe more suggestive. But by being able to switch between those styles, you're going to make that teaching encounter much more effective. The facilitated style is on, again, the spectrum, and it's really used to identify self-reflection, and for the student as well as the preceptor to recognize emotions or interactions or reactions that are occurring because of the environment, because of the interaction.
And you're talking about self-reflection on ability and knowledge.
On basically the encounter, it could be about their knowledge, but it could be about how they're feeling. So there could be times where they're feeling uncomfortable because maybe the patient's non-compliant. Maybe they really have never gotten comfortable asking about a sexual history or a drug abuse history. Maybe they had some personal things that's making those barriers, and you as a preceptor can sense they're feeling uncomfortable. Because we're all going to have to be in those uncomfortable situations, and being aware of how we feel about them is going to affect how we can move forward and being effective in patient care. So it's about being able to engage those teaching encounters. Again, as we just said, using the teaching styles, it's really what's happening in that teaching scenario is really what's going to drive what style you choose. What's happening with the learner, what's happening with the patient care. It's very important. And as you've said, there's no one style that's best, but we tend to have a preferred style. Our goal of this interaction and our covering this topic is so that you'll be aware that there's other styles, be more willing to step out there and recognize that you can use different styles in the different teaching scenarios, and to try a different style. Try to have maybe more than one preferred style. Recognize where it's most helpful. So this is kind of a summary chart that it's really helpful to look at to kind of say, where are we? Boy, these terms all sound together. It's suggestive, it's collaborative, it's facilitative, where are we? So assertive, as we mentioned, gives very, very specific directions. You're very direct in the questions that you're asking. Suggestive is just that. You're suggesting. You're leading the learner through a thought process. You're laying out the pathway, trying to make some of those connections for them. And then collaborative, really, for the most part, you think that this learner has it all together. They're able to summarize this and ready to tell you where they're thinking and where they're going. But if they're not there, you can fall back to one of these others. Facilitative one is really helping them reflect on what do they know or not know. What did they feel? Would they feel uncomfortable about the situation? Because we're all going to have patient interactions that we're not comfortable with, and we have to be aware of how we feel and how that may be challenging the actual care delivery to that patient. So it's a very important style. Not to mention, we have to be self-reflective learners throughout our whole lives. So we have to be professional development in doing self-reflection on whether, as what Dr. Owain mentioned in his section on career development, we have to reflect where are we and where are we going. And we have to do that same type of reflection of where are we as providers, where are we as educators. So that's really a very important category. So when you look at the educational objectives, what are the things you want to get out of the teaching environment? And this is what you were saying, like how do you decide which style to use? Well, really, what's your goal of that encounter? You have a patient in the ER not doing well, you may just want to know they're on track with the thought process and you're going to go right into patient care. So you'd be very directive. What's a drug dose for epinephrine? And you're going to work through that process. If you're going to give them a little more leadway to have a little more time, you say, well, we're talking about hypertension. We've talked about this before. Here are these two drugs. How are you going to put these together? You may say, tell me the difference. I'm going to order an MRI or a CAT scan in the ER. Why do we want to choose that? So those are examples of knowing where the outcome is. Collaborative style, we're going to have a little more time. Tell me your differential. Tell me how you put this all together and how you're making these decisions. Or maybe it's about lifestyle changes in coaching. We just had some discussions about how do we move forward in preventative medicine. So you want to see how are they feeling comfortable? Are they able to put this together and having a good care package or management plan for a patient? And so again, the facilitator side, how do they feel about giving bad news? They might be very challenged by that. And you as a preceptor have to recognize where they're uncomfortable. And your role in teaching is to help them walk through that, help them recognize where their bumps have been and how to get over that, how to feel good and be able to move on. So what we'd like to do is break to a couple of videos. Let's do some examples of these different interactions, and let's see if you can pick out the differences between the four different styles.
Let's do that.
All right. Hey, Michael. So we did a really good job with this patient today. So we saw Mrs. S, 46-year-old woman. Let me just kind of frame the clinical scenario.
Okay.
Past medical history of hypothyroidism, but she's really here today for us to follow up on her high blood pressure. So she's been in the last 3 months here 3 times, and she's been counseled already on dietary changes and weight loss and exercise goals. So she relates to us today. She's made some progress in that regard. She's given up her chips. She's added 15 minutes of walking twice a week during lunch hour, about 15 minutes. And she's actually achieved some weight loss of about 3 pounds. She's actually also gotten her home blood pressure monitor, so we asked her to do, and has been very compliant taking her measures. So when you look at what she has reported, 150s over 90s, that's pretty consistent with what we have in the office today. But we also have a urine dip in the office today. It shows she's a trace positive for protein.
Yeah.
So I think at this point we really have to make a decision. We're going to add some medication therapy. So we're going to really talk about adding some therapy at this point.
Okay.
So Michael, it's been very busy in the clinic today. So
Yeah.
I think you did a really good job, kind of interacting with the patient and doing a physical and exam. So I know this is your first day, so you did really well. So why don't you tell me, since we're going to start in medication therapy on this patient, what are the 3 classes of antihypertensive we would be looking at?
Well, I know we studied the ACE inhibitors and beta blockers and hydrochlorothiazide.
Yeah, so that's good. We really got at least medications in those categories.
Okay.
But you've really given me 2 categories
Okay.
and 1 specific medication. The
Oh,
hydrochlorothiazide,
yeah.
what category is that?
Oh yeah, I think that's diuretics.
Great, good
Okay.
job. So we'll have to kind of choose from one of those. I think you did a good job framing those.
Okay.
So Michael, you did a great job in the exam room today. So I think you did a good interaction, great exam. So we really had a chance to talk about hypertensive management a few times now. So I think that we're going to make a decision for starting medication. So if we were going to choose a diuretic versus an ACE inhibitor, why don't you compare and contrast for this particular patient? What would be your initial therapy for her?
I know you and I have talked about things that I've seen. Mostly we've used a lot of diuretics, like hydrochlorothiazide, but you also mentioned that if someone shows any problem with any renal function, and you mentioned there's a trace of protein in the urine, that we should really think of an ACE inhibitor. So based on what you've talked to me about, I think using an ACE inhibitor might be a better choice to go with.
Yeah, I agree. I'm really glad that you've been able to kind of pull those concepts together. You're absolutely right. That's one of the things we talked about. So I think that's great. We should actually target our therapy towards an ACE inhibitor. Let's go on in and let Mrs. S know that that's what we're going to do, and we'll talk about which one and what's the right dose for taking.
That sounds great.
Great. So Michael, I think you did a great job in the office today. I think you're feeling very comfortable. You made the patient feel comfortable with your interactions and your exam. I think that you need to really make some medication choices today. What do you think's going on with her? What would you like to do?
Well, when you look at different medications and making choices, obviously we talked about major classes and diuretics and beta blockers and ACE inhibitors. You've also made to really focus in on certain aspects which make it better for different choices. And I think you mentioned that there was a trace protein seen in the urine.
How is that important?
Well, one of the concerns of people with high blood pressure and hypertensive states is their renal function. And if you see that's a marker that may have an effect on it, and of the 3 classes, I know the ACE inhibitors are one that you've kind of really drilled in my head to think about in case of that, that renal protection. So I think I might be, if I was to make a choice, I think I'd go with the ACE inhibitor.
Yeah, I think that's a very good choice. That's a very good choice. So what will be our next steps as far as we decided on a class, now what we want to do?
Well, I think we'd reinforce all the aspects that we've already done, on lifestyle changes and keeping that up and maybe pushing that more. But the same token, I'd probably start with a lower dose of an ACE inhibitor like lisinopril or something like that, and see how the patient would tolerate it. And when they're doing their home monitoring, check to see if that makes an improvement, and see her back in the next couple of weeks or so, and to see if there's some improvement.
That's great. I think you've really pulled all those concepts together, and I think that's a really good plan for her. So let's go on and let her know that that's the plan.
Okay, that's great.
So Michael, I think you did a great job interacting with that patient
Yeah.
today, and I think you made her feel very comfortable, and you did a good job with your history and exam. So I think we need to add a medication at this point. What do you think?
Well, I agree. I mean, obviously we're trying these things, but I also got to acknowledge I sometimes feel a little frustrated. I've seen you've done a lot to work with these patients, and they don't seem to sometimes listen to all the things you've gone through. And also, I mentioned her family had a history of heart problems, and people were dying younger, and obviously they need things. But she lost a few pounds. A lot of these folks are gaining weight, and I just feel like we're not getting anywhere. And with that, and the other thing is I'm really big into the osteopathic thing, and I feel we've been so busy with this. And she mentioned that she had some neck problems. I thought, gee, I'd love to do that, but all these other big problems around her. I said, I feel like I can't even get to that point because we're just dealing with those pieces. And
That's a real important point for you to recognize your frustration. I got a sense that you were very frustrated with her as well. So I think that that's an important point for us to reflect on, because you're going to get a lot of patients that are not compliant, and you're going to feel like you're not getting very far with them.
yeah,
So I think it's really important for us to think about. We do need to make a decision about her medication.
yeah,
I agree, some of the osteopathic concepts and approaches, it's not all about manipulation. So I
Yeah.
think our focus on her lifestyle changes and getting her involved and in really engaged in her
Yeah.
care is really an important principle of the holistic view of patients.
yeah, that's true.
I agree, we can think about bringing her back for a longer visit so we can interact, but we do have to acknowledge some of your barriers and how do we get her engaged and actually get a medication started.
Yeah. Well, I know you also mentioned that she had some protein, in the urine, and you've kind of drilled to me that, when you think of that, really think of that renal end organ thing, and that's where I was looking at it saying, gee, probably an ACE inhibitor with that. And then she also mentioned to me that sometimes she takes Advil, which made me concerned because that also can increase blood pressure and cause problems. And that's why I was thinking of osteopathic manipulative treatment, because that's a safe intervention that we could do to help her with the, some of the neck discomfort she describes too.
Sure, sure, and I can see your frustration. She's
Yeah.
doing some more damage to herself with some of the other medications, so good patient education about what to avoid might be
Yeah.
something we need to focus a little bit more on this interaction.
That's okay. I'll do that.
Great.
Thanks.
So in summary, we've had a chance for you to kind of see the different styles and principles about learning, adult learning concerns. We have discussed the 4 different type of verbal teaching styles. We hope that you are able to recognize now the difference between the different styles, the advantages and disadvantages, and why you would choose certain ones in certain areas. You've identified your own style. I think you can, by looking at the videos, you can understand or reflecting how you approach a learning situation. You'll know which is your style. But I want to challenge you. Get out there and try these other styles. Recognize where your learner's not right up to that level and help them get there by being able to be a proficient at switching the styles and meeting that learner's need. Thank you. Thank you for your attention.
Thanks.